Hello, I'm Dr. Ashwin, studying community medicine, second year in Raipur. This is my YouTube channel, Community Doctor, and I'm going to talk about international health regulations and global health in my first video. Okay, I would like to discuss this topic under three headings. First, what are the conditions which leads to the development of international health regulations? Then, what are the rules and regulations should be given in the document of international health regulations? Third, what are the other informations related to international health apart from this two? Okay, this is the first. What is pandemic? Pandemic is nothing but it is an epidemic, but epidemic is occurring in a limited area. Pandemic occurring over a wide area. So if it occurs many number of people crossing the boundaries and occurs large number of people. There are two things in pandemic everyone has to know. There is no agreed criteria between the nations what to do next. And one more thing, there is no decision making process. There is no infrastructure around the decision making process regarding what the control measures to do next. This too in pandemic. But there is an infrastructure around the decision making process. There is an agreed criteria between the countries what to do next. This too should be in the PHEIC, Public Health Emergency of International Concern. So this two in this slide I mentioned two things. It should be in the pandemic, but PHEIC is completely different. There is an infrastructure and there is an agreed criteria. Okay, these are the history of pandemics. Major pandemics in the history, starting from the Antonine plague, then black death, then smallpox. This circle denotes the number of the people affected. So, in the history, bubonic plague affected many number of people, followed by the smallpox. Uh, then Spanish flu, then HIV/AIDS, and in 2021, it's a COVID-19. Okay, this is some story. Uh, Between 1830 and 1847, there is an cholera epidemic happened in the European countries. So during that time, everyone came to know that there is a need for multilateral cooperation between various sectors and multinational cooperation between various nations to control the pandemics. So after many years, WHO adopted International Sanitary Regulations ISR in 1951 for this multilateral multinational cooperation so that the pandemic can be easily controlled and ISR is replaced by ISR in 1969. Initially, there are six diseases only covered. CPY is covered like yellow fever, smallpox, relapsing fever, and typhus. Later, this six diseases is converted into three diseases. Very narrow. Only three diseases are covered. This IHR covered only three diseases. They are telling that these three diseases are notifiable diseases: cholera, plague, and yellow fever. If any country there is a cholera case, it has to report. The country officially has to report to WHO. If any country has plague, the country has to report to WHO. What they started IHR 1969, but now it is IHR 2005. So the revision happened in IHR 69. The revised one is IHR 2005. So we will leave the IHR 1969 and we will see about IHR 2005. Okay, why this IHR 1969 is revised into IHR 2005? Uh, I will tell. Okay, as I told, there are only three diseases, only narrow diseases. So there are many emerging and re-emerging diseases happening nowadays. So only three diseases is not enough. We have to make many diseases notifiable so that every pandemic can be controlled. And one more thing, as I told, this is WHO. Okay, for example, this is the WHO. This is WHO. This is member states. Under WHO, there are 196 member states. For example, India is a member state. Bangladesh is a member state. Congo is a member state in Africa. So Sri Lanka is a member state. So these are the Pakistan is a member state. So there are 196 member states under WHO. If any cases, for example, this is just an example. This is memberships, this small. This is WHO. For example, any cholera case happened in India. It has to officially, this India official person under IHR has to report it to WHO. Has to report. Okay. But the thing is, many times the reporting is not proper between these member states and WHO. So that apart from this official notification, other unofficial sources in India, unofficial sources in any member states has to report to WHO. And one more thing, there is lack of coordination between WHO and the member states, and nowadays travel is increased, trade is increased, and as I told, emerging diseases. And one more thing, for example, India. This is India. This is WHO. India reported to WHO like in my country one cholera cases that were reported. So WHO gave the rules like India has to do trade and travel restriction for some days to prevent the entry of these diseases into other nations. So India's travel and trade will be affected. So India's gross national GNP, gross national income. So trade, economy, everything is affected. So sometimes this India may fear of all these things. Even if any cholera, any yellow fever cases is there, on considering this economic loss, this member state will not report to WHO. So there is no notification during because of the fear of damaging the travel and trade restrictions. So these are the problems in old IHR. That's why IHR 1969. Okay, we remove the IHR 1969. We can revise it and we will freshly make the IHR 2005. That's why they made the IHR 2005 document. These are the history of IHR. As I told, at fourth World Health Assembly. World Health Assembly is nothing but annual meeting conducted by WHO. In that World Health Assembly, 196 memberships will participate. From each membership, persons will participate, and they will talk about the problems, regulations, everything on that. Okay. In 1969, I told ISR is replaced by IHL, 6 diseases. Later, it is converted into 3 diseases. Okay, in 2005, on considering the drawbacks, they removed the IHR 1969, not removed, just modified, and they remodified it into IHR 2005. But it entered into force in many member states in 2007 only. What is this is IHR 2005. IHR 2005 is nothing but it is a formally signed legal document by World Health Assembly. In World Health Assembly, every member states will be there. So there's like every member states has to follow this. Like for prevention and the control of international spread of the diseases and health risks without interference in trade and travel. Like, for example, this IHR has the rules and the regulations which prevent the spread of the disease, international spread of the disease, which control the international spread of the disease. So, for prevention and control, they should have to take any measures. So, these type of measures should not affect the trade and the travel of the nation, so that everyone trade and travel will not be affected. At the same time, the spread is also prevented, controlled. There are some many points given in IHR 2005. Okay. Uh, it has some 66 articles divided into 10 parts. This is a 74-page document, and it entered into force in 2007. Purpose and scope. Okay. First, I told prevent, protect, and provide a public health response to international spread of the diseases, and it is restricted to public health risk also. Preventive and international spread of the diseases, it is restricted to only public health risk. These measures should, that they are taking to control or prevent will not affect the trade, will not affect the travel, will not. There is a comparison between old and new IHR. In old, only three diseases. In present, many diseases like PHEIC. They are a new term they introduced. PHEIC. I will tell about later. Only three diseases is covered in old one. Now PHEIC. It is not limited to the disease. PHEIC. I will tell later. And previously, control happened only at the borders. Now, control happening at the source reduction. Previously, communication is only through the fax because there is no mobile phones, internet, and all. Nowadays, it is through the website. Like in the website, everyone can share the information. Like WHO can share the information to the member states can share the information to the WHO. And previously and now, if any case happened in any member states, these member states have to report to WHO within 24 hours. Now they introduced a new one, 72 hours to respond to the follow-up request. Like it, if WHO is asking something, questioning something to the member states, it has to respond within 72 hours for the follow-up request. Previously, there is no coordination between the WHO and member states. Now, I will tell one thing. This is a concept. Okay, how many regions under WHO? There are 6 regions under WHO. Southeast Asian region, Western Pacific, Eastern Mediterranean. So these are the 6 regions. Under 6 regions, these memberships will be coming. Like for example, under Southeast Asian region, India is a member state, Bangladesh is a member state, Pakistan is a member state, Sri Lanka is a member state. So under one region, there are many member states. Likewise, under WHO there are 6 memberships. Under WHO there are 6 regions. Under the 6 regions there are 196 member states. Okay. There is one contact point, WHO contact point in the WHO headquarters. This is the WHO headquarters. In this headquarters there are 6 contact points for six regions. And one more thing, these are the WHO member states. For example, WHO contact point of Southeast Asian region. This is the national focal point of India. WHO contact point, Southeast Asia region, national IHR focal point of India. If any cases, anything happened in India, it has to report to this. Okay. Through the website. This is the communication. Previously, I told this dependence and all. And one more thing, inspection and control happened at the points of entry previously. Now it emerged into detection, surveillance, reporting, and assessment and all. As I told, there are 6 regions of WHO, like Europe, Southeast Asian region, Western Pacific, Eastern Mediterranean, Africa, American region, and there are 196 member states. We completed the first section. Why IHR is why we need IHR? Because to control the pandemic, to control these things and all, to prevent this everything. Now we will see what are the information that is given in the IHR document, IHR 2005 document. We will see about basic definitions given in the IHR document. Affected means persons, packages, or cargo, containers, conveyances, goods, postal parcels, or any human remains that are infected or contaminated, or if they are carrying the source of infection or contamination, we are telling it as infected. Affected area is nothing but a geographical location where WHO is already applying some health measures. For example, yellow fever is an affected area. Africa is an affected area for yellow fever. Conveyances means like aircraft, ship, train, road vehicle, and any forms of transport on the international travel, international OH, that is conveyance. Event is nothing but the manifestation of disease, or it has a potential of uh, it has a it will create a potential for a disease. And the point of entry. Point of entry is nothing but it is a passage. It is a passage from one member state to other member state. It is a passage from one member state to other member state. Through that passage, these conveyances will go like aircraft, ship, train, everything will go. That is point of entry. Ground crossing is nothing but it is a point of land entry. Point of entry is a general term, like we can use it for airways, seaways, and landways. Point of entry is a general term. Ground crossing is a point of entry at the land. For example, any truck is going from one member state to another member state in the land. So at the border, that border area is the ground crossing. Point of entry is a broad term. For land, we will tell it as ground crossing. For airway and seaway, we will tell it as point of entry only. International traffic is nothing but movement of persons, like movement of anything, movement of person or movement of baggages, movement of cargoes across the international border. That movement is denoted as international traffic. I told conveyances are this airport, the ship, these are conveyances. That is transport. Point of entry is a border. It can be anyways, airways, seaways, landways. If it is landways, we will tell it as ground crossing. International traffic, we will that movement is the international traffic. I told WHO contact point and national IHR focal point. WHO contact point will be accessible at all times, and national IHR focal point also accessible at all times. National IHR focal point at the member state level. WHO IHR contact point is higher, like at regional level. So there are 6 WHO IHR contact point and there are 196 national IHR focal points. Okay. PHAC. PHAC is nothing but public health emergency of international concern. It is an extraordinary event. This event is nothing but has creates a potential for a disease, manifestation of the disease, and it can spread to this type of PHAC. Anything can spread. International spread will go for international spread and affects many people. And this type of PHAC, if we want to control, which requires coordinated international response, then only we will control the PHEAC. Pandemic is different, PHEAC is different. As I told 2 points in the first slide. No, here there is an agreed criteria between the nations to what to do next, and there is an infrastructure for the decision making. It's just like that the infrastructure is nothing but IHR. A situation that is serious, sudden, unusual, or unexpected, which carries the implications beyond the state national border, and which may require immediate international action for the for controlling the PHAC. These are the criteria for PHAC. Pandemic is different, PHAC is different. Okay, recommendations. Recommendations is nothing but measures for which we uh, for prevention, also for a control aspect also, what are the measures we are taking? That is the recommendations. There are two types of recommendations: temporary recommendations, standing recommendations. Temporary is nothing, it is time limited, risk specific. A duration is only 3 months. For example, during COVID time, everyone lockdown happened. That lockdown is a temporary recommendation. Standing is nothing but it is routine or periodic application specific on for this specific ongoing public health risk. Like for COVID, we now also we are telling to wear mask. That is a standing routine or periodic application. These are the notifiable diseases under IHR. Like PHAs, we will divide into two. Always notifiable disease. As I told previously, IHR 1969, only three are notifiable. Now it is into IHR 2005. PHEIC is included. PHEIC is nothing but which are the PHEIC. Two types. Always notifiable disease, potentially notifiable disease. In always, there are four: smallpox, poliomyelitis, wild type, human influenza, new virus, and SARS. These are the four. If any country has one single disease, like if India has one smallpox disease, it must be, should be notifiable to WHO. This is under always notifiable disease. Under potentially notifiable disease, again there are two sub divisions. We will see this side one. Like in this side, cholera, pneumonic, like yellow fever, viral hemorrhagic fevers like Ebola, Lassa, Marburg, and West Nile fever. The other diseases of regional concern, for example, dengue fever in India, Rift Valley fever, meningococcal disease, other biological, radionuclear, or chemical events. These are the things which should come under potentially notifiable disease. And here, this side, previously I saw four things like smallpox, SARS, and all. The diseases that is not mentioned there, and the diseases that is not mentioned in this box will comes in this box. Okay. And one more thing, those events because of unknown causes or unknown sources. This should be in this box. Previously, I told in always notifiable disease, even a single disease is notifiable. But here, is any one case of cholera is notifiable? Is any one case of yellow fever is notifiable? Absolutely not. If any diseases are of unknown causes, if any diseases of regional concern, if anything happened in one country, is any one single disease is notifiable? Not. If any cases under this is happening in one country, we have to ask four questions to that disease. If that disease answer two questions out of four questions, it should be notifiable. Previously, in all days, even a single is notifiable. Here, we have to answer four questions. We have to question four questions. If this disease answers two questions, it should be notifiable. For example, uh, cholera happened in India. We have to ask four questions. Is the event serious? Yes, no. If it is yes, then is the event unexpected? We will see the questions. Is the event serious? Is the event unexpected? Is the event spread internationally? Or is the event uh, can cause travel or trade restrictions? For example, if we are asking first question, if it answered first question, and if answered second question, it should be notified. Okay. If you answered first question, it that this is answered no. For example, if the event, if the cholera serious in India, no. The cholera is unexpected in India, yes. One question is answered. The cholera has the potential of spread internationally, yes. Two questions are answered. So it should be notifiable to WHO. I will tell India as example. I am telling cholera as example. This is just an example. So how we can say if an event is serious? How we can say an event is unexpected? So there are four questions. How we can say what is the criteria for one question? This is the criteria. To tell the event is serious, we have to see the morbidity, mortality, and population and risk and the cases in the health staff and highly infectious. It should be highly infectious and associated factors like war, national catastrophe, any disasters, and it needs immediate external assistance. These are the criteria to say the event is serious. And uh, to tell the event is unexpected, we have to, these are the criteria. The event should be unknown. The cause of the event should be unknown. And the circumstances are unusual, like cases, what's the unusual? There should be more treatment failures. And the event is unusual for the place and season. And the event is caused by the eliminated or eradicated agent. And it should be suspected due to intentional or accidental release of chemical, biological, or any radiological agent. To tell the event is likely to spread internationally, these are the criteria. Like it was unexpected and the factors alerting to cross-border implications. Like it should be it should be because of epidemic prone organism. It should be due to food import or export because it is food import and export. If there is any infection, is that it should has more potential to spread internationally. And the index case is with recent travel history, and it should be in the border areas. This sorry, and in the border areas with limited capacity for control if the event happened in the border areas. So these are the criteria for To answer the question, yes, for the third criteria. And finally, to say the event likely to result in international travel and trade restrictions. Previously, similar events lead to restriction on travel or trade, and it should be due to food import and export, and it attracts many media attention. So these are the criteria to say as for question number 4. If potentially notifiable disease, two boxes, right? If any diseases has happened in any member state, it should answer 2 out of 4 questions. Then it should be notifiable to WHO. In always notifiable disease, that's for any one case is notifiable. Okay, these are this much of rules. But till now, only 7 events are notifiable. So 7 events are declared PH, sorry, not notifiable. Only 7 events are declared PHEIC from 2009 to 2022, starting from H1N1 influenza in 2009, then Ebola in West Africa, in Ebola in Democratic Republic of Congo, then poliomyelitis in 2014, still present. Poliomyelitis is still present. Then Zika in 2016. That is the first PHAV due to arboviral disease. Then COVID-19, we know from 2020 to 2023. This is period of PHAC. Okay. COVID is still there, but it is terminated from PHAC in May 2023. And monkeypox, there are 7 events. Okay. And one more thing, first, any country has to detect and it has to verify and they have to do risk assessment of the disease and response has to be taken. First, surveillance. Any country has to do surveillance, like for the diseases, PHEAC diseases, cholera, smallpox, everything. Always notifiable disease, potentially notifiable disease. The country has to do, the member states has to do proper surveillance all the time. Surveillance activities mainly has to happen at the airports, ports, underground crossing. It is happening at the mainly at this points. Okay, 3 level at local community level, at intermediate level, and at first local community level, intermediate level, then national level. At local community level, first they will detect the events and they report the events to the upper level. In the intermediate level, they confirm the reported events. The events that is reported from the lower level, that like local community level, should go to intermediate level. They will confirm the events, they will assess, and if want, they will report it to the national level. In national level, they will assess all the reports within 48 hours, and uh, they ask to notify to WHO notification. Uh, as I told, each member state has to notify to WHO within 24 hours of assessment. After notification, this type other informations are also has to be provided, like case definitions, lab results, source and type of the risk, number of the cases, what are the health measures employed in the country, what the member state is, what difficulties are faced by the member state, and what are the supports needed by the member state. So these are the additional information which should be given from the member states to the WHO. Okay, other reports. As I told, members WHO, these are the member states. Official country notification. Now, another unofficial sources also can report to the WHO from the same member state. For example, any smallpox case is happened in the India. Till now, India has not reported it to WHO. But any unofficial source from the India can report to WHO. After reporting, WHO assess the report and again it will communicate to the India's official thing, India's official part, asking questioning some unofficial sources telling that there is one smallpox case happened in your members in your country. So WHO communicated with the official party. And the WHO maintains the confidentiality of the unofficial sources. These state parties, after questioning after getting the question from the WHO, has to respond within for 24 hours. Like they have to search and they have to respond whether that smallpox case, one case of smallpox is there or not. What is the present status? They again have to report to WHO. So one of unofficial party reporting to WHO. WHO question official country, official party, and official party has to report to WHO again within 24 hours. So that the communication is good. Okay, verification. As I told, the initial reply has to be within 24 hours. Then again, within 24 hours, available public health information has to be reported again and again. First, and one more. Then is the verification. Okay. Then is this is the verification. Then is the collaboration. WHO will collaborate with that affected state party, and they will see the adequacy of the control measures, whether the control measures taken by the country is kind of adequate or not. And the WHO offer the international assistance for on-site assessments. Uh, ex- WHO send the WHO offer the experts to the affected member state for on-site assessments, whether the adequate measures is correct or not. For any support, they can send. WHO can send. WHO will send. Determination of PHAC. Okay. For example, this is WHO, this is member state. One smallpox case happened, it should be notified to COVID happened. It should be after asking the four questions, it is notified to WHO. It is not an always notifiable disease, right? It is a potentially notifiable disease. So this COVID happened in India, so it is reported to WHO. After reporting, WHO does not determine it as PHEAC. WHO has to determine whether it is PHEAC or not. WHO has to do groundwork. Like, for example, WHO Director General, they official country notified. This is the WHO. WHO Director General seek the help of his friend. WHO Director General seek the help of his friend. This is the Director General, WHO Director General. This is the his friend emergency committee. I'm just telling in a way for understanding. Emergency committee. Emergency committee is a one part of the WHO. And WHO Director General, after asking the help, this emergency committee will assess all these things, and this emergency committee will give the idea to the Director General. Then only Director General will declare that as PHEIC. And one more thing, this emergency committee will give temporary recommendations, and it should be issued through Director General. So the Director General in constitutes in determining the PHEIC. Whether, for example, I told only 7 events are declared the PHEIC till now. For this determining this type of things, Director General will consider the information from the state party, the advice from his friend emergency committee, and the scientific principles and evidences and all. Emergency committee is nothing but they are selected from the IHR expert roster and expert advisory panels. They will constitute whether event is PHEAC or not, and they will terminate it also. COVID is determined as PHEAC on 2020. It is terminated from PHEAC on 2023. So this advice is given from emergency committee, and it should be issued through Director General because he is the head. And they can issue the temporary recommendations also. The emergency committee duration is different. For example, there are 7 events till now. So for each event, there is separate emergency committee. The duration of membership is different. Director General will select the emergency committee members based on expertise, experience, and one person from the affected member state has to be a part of emergency committee for geographical representation so that they know the country better. Okay. After after determination and all, WHO send this information to every intergovernmental organizations uh, and other member states, because other member states will prevent the entry of that disease from the affected country. They should be they must they after getting the information, other member state should be careful, because then only they will prevent the entry of the disease from the affected member state, right? So WHO will provide that information, will send the information to every membership, every intergovernmental organizations. Okay. WHO keeps the information secret. Once WHO determined it as PHAC, then it should be sent to everyone. And public health response, like IHR came into force in 2007, IHR 2005 came into force in 2007. After that, every member states has to build the capacity for surveillance, reporting, risk assessment, for taking the response within 5 years. Within 5 years of uh, entering into force of IHR 2005 in every member states, they have to build the capacities for aforementioned. As I previously mentioned, many things, right? Every member state has to build the capacities. And one more thing, WHO will provide technical guidance and assistance to the affected state party on-site, and they will send the experts for on-site assessments. And they will WHO assess the severity of international spread of the disease. WHO will see whether the measures taken by the uh, member state is adequate or not. So WHO will help the member state in each and every aspect. Okay, these are the guidelines published by the WHO for the standard operating procedures for the control of monkeypox, poliovirus, Ebola, and Marburg virus. Standard operating procedures. What are the things country has to do in response to this PHAC? And one more thing, WHO is an international organization, right? It should cooperate with other international organizations, like this is WHO, this is other international organization like UNICEF, UNDP, for asking whether the measures taken by WHO is adequate or not. Previously, WHO will help the country whether the adequate measures taken by the country is adequate or not. Now, WHO has to do this thing also. It will coordinate with its friends like other intergovernmental organizations to uh, see whether the adequate measures taken by this WHO is adequate or not. So, adequacy measures should be checked at national level also, international level also. Okay, these are the recommendations mentioned in the IHR 2005 document. These are the recommendations with respect to the persons. There is no specific health measures. The persons who is in travel, there is no specific health measures or advice for that person. I told seaways, airways, and ground crossings, surveillance has to be carried out. So at these points, they will review the travel history of the person, whether the travel history is related to any affected areas or not. It is related to persons. But they will review the medical examinations. And if possible, they will give the medical examinations for the persons on travel. They will review the proof of vaccination or prophylaxis. And if possible, if required, they will give vaccination or prophylaxis for the persons on travel. They can place the suspected persons under observation. Uh, they can implement quarantine for the suspected persons, and they can implement isolation for the affected persons. If any diseases they are suspecting, they can put the person who's on travel on quarantine. Uh, and if any person is If they are thinking this person is affected because of COVID, they can put isolation of that person because of COVID. This is just an example. And they can implement tracing of the contacts of suspect or affected person. They can refuse the entry of suspect or affected persons from unaffected areas to affected areas. And they can implement exit screening from the affected areas. So that from affected areas, if exit screening is that, they will screen the person who is affected. Previously, we saw what are the recommendations with regard to persons. These are the recommendations with regard to baggages, cargoes, things, generally things, conveyances, goods, and postal parcels. Here also, there is no specific health measures. They can review the manifest and routing, like travel history and where from here where the goods is going. Is there is the goods are coming from any affected areas? These goods are going to any affected areas, and they can review the proof of measures like any infection control, like any disinfection, any decontamination is happened in that parcel, has happened in the transport or not. If want, they can do the treatment, like they can implement inspection. If they want, they can give the treatment of baggages, cargoes, containers with disinfection, decontamination to remove the infection or contamination, including they can remove the vectors and the reservoirs. And they can use specific health measures to the safe handling of human remains. And they can, for like persons, implement isolation or quarantine of the goods. If the treatment facility is not available at the seaport or airport or ground crossings, they can completely destruct the infected or contaminated suspect baggages, cargoes at that point. If there is no treatment available, and they can refuse the departure or entry of the affected goods. And we previously we saw recommendations with regard to persons, with regard to these things. Now, point of entry. What are the capacities should be built at the point of entry? Point of entry should be airport, seaport, and the ground crossings. So, point of entry, what are the capacities must be there at every member state at any point of entry? This is general capacities. Like medical service should be available, diagnostic facilities should be available for the ill travelers, adequate staff, equipment, and premises should be available, and to provide access to the equipment and the personnel for the transport of ill travelers, provide trained personnel for the inspection of the conveyances, portable water supplies, eating establishments, flight catering facilities, good public washrooms, clean public washrooms, appropriate solid and liquid waste disposal, and the trained person for the control of the vectors and the reservoirs. So these are the general capacities. There is specific capacities regarding to the PHEAC should be present. Okay, these are the specific capacities. So the member state should have public health emergency contingency plan, including the nomination of coordinator and contact points, agencies and services for control of the uh, for prevention and control of the PHEAC. It should have some plan for prevention and control of the PHEAC. Okay. And for affected and travelers and animals, it should provide local medical and veterinary facilities, and separate space is has to be available to interview suspect or affected persons. And for quarantine of suspected persons, facilities should be available for disinfection, de-ratting, disinfection, and decontamination to treat the baggages, cargo, containers, conveyances, goods, and postal parcels. These measures uh, for these measures proper for proper materials and proper location should be available, and entry and exit controls should be there, and to provide access to specially designed equipment. So for any health worker, they have to give special equipment for the for the prevention of for the protection of the health personnel. So some specific designed equipment should be provided to the health persons, and this measure should be available. Like D-rating is not like that. This is just an example. And one more thing, previously we saw recommendations with regard to persons, with regard to things, and the point of entry, what are the capacities, general capacities, and capacities related to PHEAC. Now, what are the health measures on arrival and departure? Health measures. Okay. With regard to travelers, uh, information like this authority has to see the information regarding the traveler destination and the traveler's planned route, and they can review the traveler's health documents, and they can give non-invasive medical examination if required. They can inspect the things, baggages, cargoes, containers for any infection or not. One more thing that without consent, there is no such medical examination, no such vaccination, no such prophylaxis should be given to the travelers. Consent has to be get. Consent is important, right? And one more thing, for example, in any point of entry, any seaport, airport, and ground crossings, if traveler should be given, if traveler is required any vaccination, for example, a traveler is going is not vaccinated for yellow fever, and he is coming, uh, and he is going from affect, unaffected area to affected area. So while going, he has to be given yellow fever vaccination. So while giving vaccination, the person should be told the benefits of vaccination. And if the person is refusing, the person should be told the non-use of vaccination on top. If they are like, we have to advise everything regarding the use and non-use of vaccination, regarding the use and non-use of prophylaxis. And one more thing, if any medical examination and medical procedure and vaccination or prophylaxis is given, it should be given according to the national or international safety guidelines and standards. It should be given as per the standards. Okay, these are the certificates related to ship. There are two certificates: ship sanitation control exemption certificate and ship sanitation control certificate. Two certificates. For example, if any authority is inspecting the ship, if the ship is free of vectors, there is no vectors, there are no disease reservoirs is there. Okay. The ship should be rewarded with ship sanitation control exemption certificate. Okay. And one more thing, if some risk is present, and this after applying the measures, control measures, there is no risk. The control measures is successfully carried out. Then the ship is given ship sanitation control exemption certificate. There are two certificates in different situations. For example, in ship sanitation control exemption certificate, uh, this what are the areas inspected, what are the evidence found, and what are the in ship sanitation control certificate, like after applying the measures, what are the control measures applied, everything should be given. And one more thing, the certificate's maximum validity is 6 months. And additional information should be there, like regarding foods, what are the source of food, what are the storage of the food, regarding water, waste, swimming pools, medical facilities, other areas inspected. And the issuing officer has to sign this certificate. Okay. Previously, we saw two types of certificates related to health. Now, there is one thing, maritime declaration of the health. Example, a ship is coming from some country, and it is coming to Visakhapatnam in India. Before arriving or at the arrival, this ship captain has to give maritime declaration of health to the authority of Visakhapatnam. What is this maritime declaration of the health should be there? This document should be given, signed by the ship captain and countersigned by the ship surgeon. So what is this maritime declaration of the health? It is nothing but whether the ship has this any ship sanitation exemption certificate, or whether this ship has ship sanitation control certificate, and what are the list of ports visited in the last 30 days, what a list of crew members the last 30 days, is any person died on the travel, is any ill passengers greater than the normal expected, or is there any cases, or is there any cases consulted medical practitioner or not, whether they initiated medical treatment or not, or any condition which can lead to spread of the disease, what are the sanitation measures applied, or any sick animal or pet, or any uh, persons having the fever, prostration, decreased consciousness, glandular swelling, cough or shortness of breath, unusual bleeding, skin rash. So these are the diseases should be ticked, like write an yes or no. They have to write and they have to sign it. It has to be signed by the master and ship surgeon, and it has to be given at the arrival to the concerned authority where they are arriving. Ship has to give it to the authority where they are landing. For ship, it is there. For airport, here is the next. Health part of aircraft general declaration. It should be signed by the pilot in command. For ship, it is signed by the ship captain. So it is signed by the pilot in command. Like it is also mentioned like is there any patient having persistent coughing, impaired breathing, persistent diarrhea, or persistent vomiting, any signs of communicable diseases, and it should be signed by the pilot in command, and it should be given to the concerned authority. Now, these are the vector-borne diseases under surveillance at each point of entry. There are seven: malaria, dengue, chikungunya, yellow fever, Zika virus, plague, and leptospirosis. These are the top most diseases under surveillance. Everything is under surveillance, but these are the top most vector-borne diseases under surveillance at the point of entry. And these are the top vectors under surveillance: mosquitoes, sandflies, rodents, flies, flea, louse, ticks, mites. I would like to show one video. Okay, what is what is mentioned? What is the conclusion from the video? The surveillance has to be carried around 400 meter of any point of entry. If there is any vectors, vector integrated vector management has to be carried out to kill the vectors. Their own competent authority will be there. He filling that vector after seeing it. Okay, so not by letting the fire, by the integrated vector management. For mosquito control, these are the things: environmental management, mechanical control, biological control, chemical control, and insecticide control. For rodent control, for flea control, it should be used. And for cockroaches, these are the things should be used for control. For house flies, these are the things should be used. I get this information from the Airport Authority of India website. So these are the things which should be used at the followed at the India level. Okay. And one more thing: vaccination prophylaxis and related certificates. If any person is given vaccination at the any health facility or any point of entry, certificates has to be provided. Only if the person is showing the certificate, then only he is allowed to enter or depart. So certificates, these certificates are valid only if the vaccination or prophylaxis is approved by the WHO. And the certificate must have the signature of the clinician or signature of any medical practitioners or authorized health workers who is supervising the administering of the vaccine. And it should contain the health facility stamp where they get the vaccine. And the content matter should be written in English or French or any another language apart from English or French, like in Tamil, Hindi, Telugu, everything, anything. And the certificates are individual specific. So children are also have to provide specific certificates if they are vaccinated. So individual specific. Parent or guardian should sign the certificate when the child is unable to write, or the signature of the if the person is illiterate, they are not able to sign. So any person mark should be placed in the certificate, like thumb mark. And for one more thing, for yellow fever, example, the stick embryo allergy, egg allergy is a contraindication for giving yellow fever vaccination. So for these type of persons, the supervising clinicians have to mention in the certificate, like because of the yellow fever allergy only, sick embryo allergy or egg allergy, the person is not given vaccination. And with the signature of the clinician, the person should be given certificate. If the person is going to any yellow fever endemic areas, they should show the certificate to the competent authority. Even if we are not giving the vaccine because of contraindication, for those people also we have to give certificates. And the same certificate should be given by the armed forces is acceptable. Like if it contains the medical information and the statement is mentioned in English or French or any another language, apart from the health facility like hospitals and all, the same document issued by the armed forces is eligible if it contains these things. Here, I will tell yellow fever as an example. This incubation period is 6 days, and yellow fever vaccination is eligible after 10 days of administration, and it is the protection is lifelong of the person. Validity is lifelong for the certificate. Any person leaving the affected area, any person going to the affected area has to be provided with yellow fever vaccination. One more thing, I will tell. If a traveler in possession of the possession of a certificate of vaccination against yellow fever, which is not valid. For example, a person is showing the yellow fever vaccination at the point of entry airport. By that time, it is not valid. If the person is able to depart, yes. If the person is able to depart from the uh, country, for example, uh, any person coming from the Africa and he's coming to India. In India there is no yellow fever cases. So in Africa, the person is showing the yellow fever certificate, but that time the certificate is not valid. Even the certificate is not valid, the person is able to depart to India under one condition, I will tell. And one more thing, uh, if the person is vaccinated against yellow fever, he should not be um, treated as a suspect. Country designated specific yellow fever vaccination centers. The state parties designated many yellow fever vaccinated centers in its territory. Like in Raipur also one yellow fever vaccination center in immunization clinic is there. So many centers in India is giving yellow fever vaccination. The persons working at the point of the entry should have the yellow fever vaccination certificate. Here I told right, the person uh, is showing the yellow fever certificate, or the person here. Sorry. The person is unable to provide a valid certificate or yellow fever during the departure or during the entry. So these type of person should be quarantined for 6 days, because the incubation period for yellow fever is 6 days. During the quarantine, if there is no symptoms of yellow fever, then only the person is uh, allowed to depart. If the person is unable to provide the certificate, and if the person is contraindicated, previously I told right, if the person is contraindicated for vaccination, and one more thing, if the person is if the person here I confused so much. Sorry, I will tell it clearly. If the person is unable to provide the certificate, or if the person's yellow fever vaccination is not valid, the person should be quarantined for 6 days. If there is no symptoms of yellow fever, then only the person is allowed for entry or allowed for departure. Here, if the person is contraindicated for yellow fever, he should not be quarantined. He should not be put quarantined like previously. He should be given advice regarding he should be given awareness regarding the risk factors, transmission of yellow fever, regarding the protection of yellow fever, and this person should be put under monitoring. And we have to tell that person, if you're getting any symptoms of yellow fever, you have to report to the health facility or a concerned authority. We have to tell all these things, and we have to allow the patient, we have to depart the patient. These are the yellow fever endemic areas last updated on 2023 by WHO. Okay, we saw what are the conditions lead to the development of IHR and what are the things should be given in the IHR 2005 document. Finally, these are the third thing, conditions, other conditions related to international health. As I told, IHR also tells about the health clearance of human remains. If it is cremated remains, it should place in a sealed or not similar container, hermetically placed. Hermetically placed in means the air cannot come in, the air cannot go out. If the human remains is uncremated, like flesh, it should be placed in a sealed zinc or thin lined wood. And if the death is due to communicable diseases, after cremation only it is allowed to depart. Okay. India point of entry organizations, as I told, point of entry is three: airport, seaport, land entry. The concerned authority who is doing the previously from starting first slide to now, I told many things like measures, inspections, everything right. Uh, this should be taken by the concerned authority. This concerned authority should be at the point of entry. In airport, the concerned authority is named as airport health organizations. In seaport, port health organizations. Land border health units. They should follow they are following the international health regulations globally. Like everyone is following the international health regulations. In India, apart from this, international aircraft public health rules and Indian aircraft public health rules and Indian port health rules is followed. Uh, international health division. Okay, these international health organizations, like this point of entry organizations, airport health organizations, port health organizations, and the land border health units, they are the ground level workers. They should be headed by the International Health Division under Director General of Health Services, Ministry of Family Welfare. They are the head. This point of health organizations are the ground level workers. And they can, this point of entry organizations prevent the spread of the disease, and they can provide safe, healthy environment at the point of the entries to travelers and the staff working. Previously, I told these are the things, main aim for IHR. And GOARN. GOARN is nothing but it is a WHO network of 250 technical institutions and networks globally. Globally, there is 250 institutions and networks of WHO. They can respond to acute public health events. They can recruit the staff. They can give the resources to the affected countries. This network is a GOARN network. It should be coordinated by GOARN operational support team, and it is governed by GOARN steering committee. Okay. GOARN OST is a ground level worker. GOARN steering committee is a head. The ground level worker will do day-to-day activities, outbreak response missions, network activities, and communications. This head steering committee is a 21 partner institution whose planning, implement, and evaluation of all the things. And they can prepare the network activities and they can prepare the strategic goals. So steering committee is a head. The ground level worker is a GOARN OST, operational support team. As I told previously, International Health Division of Ministry of Health and Family Welfare is the head. Point of health entry organization is a ground level worker. Here in GOARN steering committee is a head and GOARN OST is a ground level worker. Okay. Previously, at the start of the presentation, I told right. This is the WHO contact point. This is the National IHR focal point. They are communicating through a website. This website is event information site. Through this event information site, WHO can coordinate with state parties, and even state parties also coordinate with each other. This is flag for Nepal, I think. And it DONS. DONS is nothing but disease outbreak news. It provides confirmed acute public health events. It gives the information of confirmed acute public health events. EAS is only these authorities can message with each other. But DONS is even accessible to us. Now you are seeing this video, you can go and if you are going and typing DONS in website, you can get the news. What are the confirmed acute public health events at present? Like we can search by keywords, we can search by regions, countries, we can search from this state to this state how many events outbreak happened all over the world. We can search through these filters. Last in 1st December 2023, influenza outbreak happened. And in 3rd October 2023, Nipah virus infection outbreak happened in India. These are the screenshots from the websites. And final one more thing, Basel Convention. What is Basel Convention? Here, what this guy, what this authority is doing? He is stopping one vehicle. This vehicle contains some biomedical waste. He's preventing the entry of vehicles from one country to another country. What this indicates? This is nothing but Basel Convention. Like it was adopted in 1989 and came into force in 1992. With 175 parties, including India, it has universal membership. It is nothing but this convention aims to protect the human health and environment against the adverse effects of generation and transboundary movements of hazardous and other biomedical wastes. And these are the SWOT analysis for this presentation. As I told, there is very integration between various sectors. SWOT analysis of not SWOT analysis of IHR, not this presentation. Uh, Here I told there is integration between various sectors, and adequacy happens at national level and the international level also. Adequacy of check-in adequacy of control measures, and there is coordination between various state parties and international organizations. It makes us way for safe travel and trade. Weakness. As I told, capacity. Till now, there is limited capacity in many member states, and there is lack of coordination and networking and transparency in sharing the epidemiological data between the state parties. And one more thing, there is inadequate equipment for data capturing, data storage, and all. And there is lack of awareness regarding the IHR for in healthcare. Lack of regarding the IHR of national and international health staff. They are not aware of IHR. And opportunities is we can screen along with the surveillance at the ports, we can screen NCDs also, and it prevents bioterrorism threats. There is lack of adequate funding at country level for the measures and all, and the relatively high capacity to detect outbreaks does indeed fall short in face of COVID-19 pandemic. For example, if any pandemic occurred, we are not considering earlier. We ignore the other surveillance and all. So these are the threats. Thank you. Thank you.